This is a case of a silicone plate haptic intraocular lens exchange. The patient had had cataract surgery 9 years prior and had noted an irregular pupil ever since surgery. When I saw her in consultation, I noted that the superior haptic was in the capsular bag, but the inferior haptic was in the anterior chamber angle. Furthermore, the patient had developed uveitic glaucoma. A decision was made to exchange the intraocular lens. First, two side port incisions are created. The anterior chamber is filled with viscoat. Extra care must be taken as the posterior capsule is open. Here we are prolapsing the superior haptic out of the capsular bag and into the anterior chamber. The main incision is created with a 3.2 millimeter diamond blade. MST microinstruments and a lens cutter are used to trisect the lens. The first segment is removed through the main incision. The remaining lens fragment is then cut in half. Once this fragment has been cut in half, care must be taken that neither piece falls through the opening in the posterior capsule. Therefore, our next step as we complete this cut through the intraocular lens is to have viscoelastic to inject behind the IOL fragments. Here, more viscoat is injected behind the lens fragments. Finally, the remaining IOL fragments can be removed from the anterior chamber. It is noted that the iris defect persists inferiorly, and in fact, the iris has scarred into the angle. As there is an opening in the posterior capsule, vitreous did present at the wound. And an anterior vitrectomy was performed. Once the anterior vitrectomy is complete, viscoat is then injected to fill the ciliary sulcus, which will be the location of the new intraocular lens. Here, a three-piece intraocular lens is injected into the ciliary sulcus. The viscoelastic is removed from the anterior chamber. Myochol is injected to constrict the pupil. The new intraocular lens is well centered. This is just one way to explant a silicone plate haptic IOL. I hope you found this informative. Thank you for watching.